Thanks again, Dr. Gusani, for talking to us during Pancreas Week, no less. Tell me, how are pancreatic cancers usually showing up, say, to the general surgeon or in the community that eventually come to you?
Right. Well, thanks again for having me on, Chris. It's a pleasure as always to Skype with you. And as you mentioned, it is a Pancreatic Cancer Awareness Month. We wear purple in November because November is Pancreatic Cancer Awareness Month, and we try to raise awareness for what is sometimes a difficult to diagnose cancer. Getting to your question, pancreatic cancer most commonly presents in a pretty advanced state, and the symptoms can include things like obstructive jaundice. So the classic thing we all learned from our textbooks is painless obstructive jaundice in an older patient is pancreatic or periampullary cancer until proven otherwise, and I think that's still an important tenet today. Other symptoms can be more subtle, things that are very common, things like nausea, early satiety, weight loss, difficulties eating, or pain that radiates to the back from the mid-epigastric area.
And how about that group of patients who get sent to have their gallbladder taken out and they're found to have continued symptoms or lab findings?
Yeah, so Chris, pancreatic cancer is the 9th most common cancer in the United States, but there's only 40,000 patients diagnosed per year. It's not that common of a cancer, so other things are much more common, things like gallstone disease and gallbladder disease. And so in the average patient, we'll often have right upper quadrant symptoms, either jaundice or pain or something that looks like biliary colic, and it often is. I think the important thing is to have awareness, though, that in the older patient age group, we always have to think that it could be something more sinister, and to have a high index of suspicion if something doesn't look right, or if there's a mass in the head of the pancreas, or even some subtle findings that look like a distal biliary stricture. That should be more concerning for for pancreatic cancer than potentially for stone disease.
Okay, let's say I have a patient who continues to have elevated liver function tests after I've taken the gallbladder out, and so far all I've had is an ultrasound. How should I expedite that patient's care if I have a clinical suspicion now that it may be pancreatitis or maybe pancreatic cancer?
Sure. Yeah, I think good cross-sectional imaging is critically important. Usually we'll ask for triphasic CT scan or MRI, where that includes imaging that has no contrast, no IV contrast, includes contrast in the arterial phase as well as in the venous phase. But the critical thing is the IV contrast. Most lesions of the pancreas are going to be hypodense or hypovascular, and so they'll show up sort of as a darker area than the surrounding substance of the pancreas. And then neuroendocrine tumors, which are more rare forms of pancreatic cancer, are usually hypervascular, so they'll be more bright than the surrounding pancreas. And for those, we often will need the arterial scan. But a good cross-sectional imaging is critical, and I think in 2015 we can make an argument that that should be sort of the first step for most people's workup.
Sure. And let's say we find a tumor in the head of the pancreas and we suspect cancer. What's the standard operative procedure for that patient now?
Well, so before we get to that, our friends in gastroenterology have made great strides, and they help us in so many different situations. But I think the key now is that modern gastroenterology tests can help us not only palliate the symptoms of jaundice with an ERCP and a stent, but also get a diagnosis. They can do an endoscopic ultrasound to examine the areas of the pancreas and do a directed fine needle aspiration, which can help us get the diagnosis. You don't always have to have a diagnosis, and still, the teaching is that a mass in the head of the pancreas is cancer until proven otherwise. But most people will end up having these gastroenterology procedures done, and will often have a diagnosis before we would think about going to the operating room.
Okay, very good. And what do you do in the operating room?
Yeah, so there's there's only two main surgeries for the pancreas. There are others and variants of these, but for lesions of the pancreatic head, which are most common, about 2/3 of tumors in the pancreas are in the pancreatic head and uncinate process. Those are the ones that present with jaundice and blockage of the bile or pancreatic ducts. For those, the standard procedure is a Whipple procedure, which is a pancreaticoduodenectomy, where we take the head of the pancreas and organs with which it shares a blood supply. So the duodenum and the distal bile duct are the chief among those. We also take the gallbladder, and classic Whipple includes taking the antrum of the stomach. Pylorus preserving Whipple saves the antrum of the stomach but takes the duodenum just distal to the pylorus, and those are about equivalent in terms of outcomes. So it's sort of the surgeon's preference which one we do.
Very good. Last words, pancreatic cancer.
I think detection and index of suspicion is the key. It's the 9th most common cancer, but the 3rd or 4th highest common cause of death in men and women in this country. Often can be found late, but I think we need to have a high index of suspicion in an older patient that subtle GI symptoms, jaundice, pain, anorexia, and weight loss could be something more sinister than common problems, and we should be thinking about those in our workup.
Thanks again, Dr. Gusani.
Thanks a lot, Chris.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.